My name is Talfrin Fox. I've been on the server for 3 and a bit years, not so much recently. My time here has been mainly EMS roleplay, medical roleplay. It's kind of what I enjoy the most. I'm not a professional in real life, so my knowledge is just based on reading books and being a bit of a nerd about it. And I'm going to try not to overwhelm you with information today, but it is going to be a lot all at once. I've tried to make it as visual as possible because people learn in different ways. Disclaimer, like I said, none of this is real knowledge, so only take it for what it is, which is for roleplay. It's not to be used in obviously any other context. Okay, well, I guess, yeah, this is where we got up to. So the things we'll cover today is how to communicate with your patient and ensuring your own safety. I think it's really important to not forget that we are still role playing, and it's easy to get lost in all this medical knowledge when you're trying to role play. So just try and keep your role play quality at the forefront of everything you do, even if it sacrifices medical accuracy. So we're going to go through the steps of response and understanding your patient, some of the legal implications of your medical care that you've got to be aware of. We've had, when I was chief in the MS, we had a case where one of the medics didn't announce who they were when they arrived at the scene, and they got in some lawsuit. It's quite a good role play. Understanding vitals is a nice addition to add some communication when you're role playing. Breakdown the steps of response, which is we're going to go into details of the various kind of injuries and ailments and how to treat them. I'm going to go into some basic pharmacology, field pharmacology, where applicable. It's mainly just gas administration and a small selection of drugs you can use. And specific injuries. So we're going to cover a thing called a tension pneumothorax. Hopefully it'll make more sense when we get there, but yeah, we'll go into some specific injuries. I guess I'll say this now. If you have any questions, please interrupt me. I'll try and answer them to the best of my ability. Like I said, I'm not a professional, and I haven't picked this stuff up for a little bit, to be completely honest with you. So it's going to be a bit of a memory game for me. But let's get started. So we're first going to go into communication. Seems self-explanatory, but ensuring you present your name, rank, and department when you arrive at the scene to your patient to avoid any possible legal altercations. Respect and listen to your patient's concerns. They know best. It's kind of like the service industry in a sense. You've got to listen to them and what they're saying, and it can help with the role play too. Just to try and roll with what they're doing rather than trying to just go through the processes we're gonna go through here today. Essentially, what I want to try and get out of this by the end of it is to give you a set of skills that will allow you to create a realistic roleplay experience, but also a fun one for the patient and yourself. Yeah, like I said, just try and keep the roleplay at the back of your mind when we're going through all this stuff, because it's easy to get bogged down. So working with your patient, not for them, that's kind of just basically saying the same thing. You want to engage in the role play rather than just spewing out medical jargon at them. Okay, so scene safety. It's the first thing you do when you arrive at the scene for a patient. If you are dead on the floor after a vehicle collides with you, you are as much use as they are. So just making sure that when you're, for instance, if you're on a highway and you've pulled up next to your patient, just look around for other cars, because this seems like something that wouldn't transfer to the game, but it does. I've seen medics just get too caught up in the rescuing. If we've got a bunch of calls coming in, it's easy to get too caught up in the rescue that you just step out and do something silly, and then you've got another casualty to deal with. So active scene management. I don't know how many people here are TAC Ops trained. Is anyone here TAC Ops trained? Oh, nice. Okay. Yeah. Okay. So active scene management, robberies, and active shooting scenes. It's the police's job to deal with that, as well as the Coast Guards, where necessary. But if you're acting in a medical respect, generally the protocol is that you stage yourself away from the scene until you enter. This is kind of maybe more relevant to medics. I'm not sure if during TAC Ops training, you said you've done rifle training. It's not the same as TAC Ops training. If you declare yourself as a medic during a TAC Ops training session, they'll teach you how to stay back from the scene and make sure you're providing as much use as possible to the police that are clearing rooms and stuff. So maybe that's something to go through, but get you signed up on the TAC Ops trainings. Don't know if they're still running them. Assuming they are. Like clearing rooms and stuff. Oh, okay, nice, sweet. Well, that's fine. So yeah, it's just if you're acting in a medical regard during a TAC Ops operation, it's just about being a bit more tactical and using something called TCCC, Tactical Combat Casualty Care. It's about helping where you can so that you can either get them back in the field or get them to the hospital ASAP. So police assistance, obviously don't do anything if you think it's going to be too much of a big deal. Some of this stuff is a bit more relevant to EMS because that's kind of where I've taken all my stuff from. I think you'll probably be more competent to engage in more violent scenes, but always call for police if you're ever in doubt. So standard safety protocol, that's pretty much what I've already said, is just make sure you don't put yourself in harm's way. Another good instance is if you're going to save someone in the hunting area, it's important to make sure what killed them or knocked them down, it could be an animal, also doesn't knock you down. Seen that happen definitely more than once. So yeah, just keep your wits about you and make sure you're not putting yourself in harm's way. Okay, so we're going to go through the basic steps of response. So the first thing you want to observe is what we call major hemorrhaging or major bleeding. It can kill in about 5 minutes, whether it's internal or external. And the key to stemming any major bleeds is just pressure. I think that's something probably most people already know. One method is with something called a tourniquet or tourniquet. I don't know how you pronounce it properly, but essentially just a band that tightens. Tourniquet. A tourniquet. Yeah, you can use a tourniquet if you want. A tourniquet. You can use a whatever the fuck it's called, which stems the bleeding. But major hemorrhaging, there's little you can do about it in the field. It's just getting them to the hospital. Airway management. Yeah. Yeah, that's how that works. Just stick a tourniquet around their neck. Definitely won't choke them or anything. So yeah, just pressure is key. So the next one is airways, making sure that your airway is clear, and you can use two methods to make sure it's open. You've got the head tilt chin lift, where you just gently lift their head back and move their mouth open, or the jaw thrust mover, which is slightly more aggressive. It's usually used for possible choking obstructions. It's a bit faster and helps to clear potential obstructions, which brings us on to the next thing. Something that probably you're going to encounter quite a lot as Coast Guard. It's mainly the thing we'll deal with is choking patients. So clearing obstructions is the number one priority. Now, if you've got someone choking on liquids, rolling them on their side is the first step. Hoping that they can cough it up themselves, use their own respirations to exhale the water. But there are other ways you can clear obstructions. You've got the old 5 pats on the back, and then the Heimlich maneuver. It's more for solid obstructions, but for more liquid ones, it could be vomit or blood or just water. Again, in this case, you can use a suction machine. Have I lost anyone already? just wanna get a gauge.
Mm-mm.
All good?
Mm-hmm.
Okay, I'll carry on. So yes, breathing. Breathing's the next one. You've got to decide whether you want to ventilate your patient. It's called ventilation. There's going to be a few methods we'll go through in a bit. This is kind of just an overview. But your airway and your decision whether you support that breathing is dependent on their level of consciousness and ability to breathe correctly. So circulation, observing the pulse. Obviously, begin CPR if none is detected. We'll cover that again during the vital section. And something called capillary refill. So if you squeeze your own finger, you'll see it will go white and then it will go back to pink pretty much within a second. If it doesn't, you might have an issue with your blood pressure. Maybe something to look at. But capillary refill is a good indication of possible internal bleeding or just low blood pressure or shock or something like that. So the next one is disability. So you can use something called the AVPU scale, which stands for alertness, visual, pain, unresponsiveness. This is to gauge their level of alertness, or to gauge their level of consciousness, rather. So alertness, are they passively responding to their surroundings? V for visual, are they responding to visual stimuli such as light? P for pain, are they responding to painful stimuli like a squeeze on the finger or something called the trap muscle? It's a little muscle on the neck and it's quite painful to be squeezed. Or U, are they completely unresponsive? So it's just a way to determine what level they're at. And then exposure, it's about removing potential obstructions if you need to do defibrillation, removing clothing, or being aware of their environment. If they've gone into shock and it's really cold, just making sure that you're being aware of the environment around them and accounting for that in your treatment. Okay. Now we're going to go down into understanding your patient. Does anyone have any questions on this before we move on? All right. Okie dokie. So you're probably going to notice this a bit of a theme. There's quite a few acronyms. SAMPLE is the first one. So we got SAMPLE, which stands for symptoms, allergies, medication, past medical history, last oral intake, and events leading up. So S for symptoms, understand what kind of pain the patient's feeling and its location. We'll go into analyzing pain in a bit more detail later on. Allergies, understanding that allergies could affect your treatment and it could affect how they respond to treatment. Medication, pretty much the same thing. Making sure there's no conflicts between what you're administering and what they take. Past medical history, again, if they are hyperglycemic, if they've got diabetes, something like that, it can affect your medical treatment. Last oral intake, possible aspirations of food, poisonous substances. It can help determine, again, how you treat, and it can help diagnose possible ailments and events leading up, again, to understand. I mean, if they're in front of their bonnet and the glass window is smashed, it's pretty fucking obvious what's happened to them. So it doesn't take much to work out there. Okay, so again, this is kind of used to help to help decide how you're going to go on with your treatment. Okay, we're going to go into some legislation. The boring part, but also important. So consent. Consent's a strange one, but generally, wherever the patient has the ability to provide it, you should ask for consent to do any form of invasive medical action, whether it's intubation or applying a mask or something like that, or giving them oxygen. Obviously, it's different for children. In the same way that if they have some lack of mental state, like it says there, a medic must be able to justify unconsenting medical procedure. So you must be able to essentially legally defend why you decided to make a procedure without consent, based on lack of necessary mental state. If they're unconscious, it's pretty obvious why you'd be able to do that. Just always keep in mind that you're acting in your patient's best interest. So ADRT, this is something called the Advanced Decision to Refuse Treatment. Possible pre-existing conditions, the L kind of thing. Don't resuscitate, do not resuscitate kind of thing. That's an advanced decision to refuse treatment. It's important to follow these. You could end up in some kind of lawsuit. Another one I didn't put there is confidentiality. Exercising a patient's right to confidentiality with respect to their medical ailments is important. It is important, however, to recognize that if a patient says something incriminating to you, it's not your job to speculate it's not your job to speculate. Your job is to report it to the police, or if it is in your jurisdiction, act in that regard. Yeah. Again, that's kind of one I didn't put in here because it doesn't really apply. But it's more important for medics, but still relevant. Okay. Have I still got everyone?
Mm-hmm.
Woo. You know it. Okay, so we're going to go to some vitals. And I hope you are all taking this in or making some kind of notes, because you are going to be tested on it and you can fail. I fail people often on this. I guess I have to give a bit of a disclaimer. This level of knowledge is what I usually teach to high paramedics. I was asked by Ash to do a high level lesson for you, so this is kind of as in-depth as it gets. So I hope you take it in. Alrighty. So vitals, understanding vitals. It's kind of a good way to add realism to your patient, and you can do the whole when you arrive at the hospital, they're tachycardic at 45 over. Yeah, whatever. You can go through the vitals to make your roleplay sound a bit more authentic. It's fun. A very objective sense of fun, but yeah. So the pulse. You probably all know what the pulse is. You can read it in two places: radial pulse or carotid pulse. Use your index and middle finger. Normal rates between 60 and 100 beats per minute. And then there's two states of pulse rate. One known as bradycardia, which is where they're less than 60 beats per minute, or tachycardia, which is greater than 100 beats per minute. Bradycardia can be a symptom of, or an indicator of possible internal bleeding if you haven't noticed any external bleeding, or it could be a sign of shock, something along those lines. We'll go into that in more detail. So respirations. Again, this is kind of just there's no necessary tool for understanding respirations. Audible and feeling. Usual breaths per minute between 12 and 20. The things you got to be aware of is the rhythm and the pattern. Is it short, long, frequent, infrequent? and also the depth slash quality of the breathing. Is it labored breathing? Is it shallow? But the reason I've put that instrument to the left there, that's something called a sphygmomanometer. It's used for, you probably all seen one before, it's used for measuring blood pressure. And it is kind of related to respirations in the sense that it's kind of an indicator of oxygenation. We'll come on to another indicator for that. But there's kind of some states to go through. Maybe I should have put blood pressure as a separate one, but oh well, too late now. So there's some, I don't know if anyone understands, how you read blood pressure, but you've got two different readings usually, called the systolic and diastolic readings. I have to be honest, I've never fully understood the blood pressure. I understand kind of the difference between them, systolic and diastolic. But really, just some key things to note is systolic blood pressure is not less than 80, and diastolic is not greater than 90. And that's usually measured in, I think, milliliters of mercury, which is basically a pressure reading. We won't go into too much detail there because it's just too complicated. So skin color, it's kind of a good indicator of their current state. Pink is normal. Pale gray indicates some kind of shock. Flushed could be CO2 poisoning or just fever, less severely. Blue, hypoxia. This image here to the right is kind of a good hypoxic. It's hypoxia. Looks like hypoxia is essentially a lack of oxygenation in the blood. That's why you turn blue. And yellow, indicator of liver failure. You'll probably find quite a few drunks, I'm sure, in the city. Don't know how many people are role-playing drunks now, but used to be a thing. So another one is the texture of the skin. Is it wet or dry? Is it warm, cold, or hot? Some good symptoms to take into account in your treatment. Okay, pupils. Pupillary response. You can use a pin torch to assess, shine a light in their eye and see how their pupils react. Use this PEARL acronym. Are the pupils equal and round, and are they reactive to light? Here's some kind of in-depth kinds of responses. You don't really need to know these, but just maybe one to remember is that uneven dilation is usually an indication of some kind of head injury. Or it says here like nerve compression. Okay, and it's usually quite heavy concussion for your pupils to react. Next one is this is what we call oxygen saturation. So it's called a pulse oximeter, this tool to the left here, and it's rated between 0 and 100%. It's essentially, if you're at 100%, your blood is 100% saturated with oxygen. That's all that thing does. Now, usually a normal rate is between 93, it says 95 there, that shouldn't say 95, that should say 100, or 99 rather. So, let's do that again. So somewhere between 93 and 99%. Yeah, if we go below 93%, they're hypoxic, and you need to do some kind of oxygen therapy or give them some kind of oxygen to get those levels back up. Next one, if you have a diabetic patient, or they've just had too many Red Bulls, you can help diagnose what it could be using blood glucose levels. So there's two kind of states you can be in terms of a glycemic range. You got less than 60, then known as hypoglycemia or hypoglycemic, or greater than 150, which means they're hyperglycemic or in hyperglycemia. So if they've got low levels of glucose, easy solution, give them glucose pouches. If they have high levels of glucose, depending on the case, you can use insulin. Again, it's a bit meh, but I think you can just act to your best ability here. So that's all of the that's all of the vitals. Does anyone have any questions on these before we move on? Alrighty. Well, I'm going to take just 2 minutes to go and grab a quick drink because I've been talking for just a little bit here, and I know it's really a massive amount to consume. I'll send this PowerPoint to anyone who wants it. It is a PowerPoint presentation. It's not a Google one, so it's not that easy to distribute, but I'm happy to send it around for anyone that wants it.
Yeah, can I have it, please?
Yeah, sure. Yeah, I'll do it afterwards.
Yeah.
But yeah, I'm just going to go grab a glass of water because I can hear my voice going a bit croaky. I'll give you 5 minutes of not hearing me. Okay, back in a bit.